I got little Snoopy. It's Snoopy. Okay. Yes, we are live. Hey, everyone. And this is an impromptu live. I didn't know I was going to do this today. If you follow my mailing list, chefaj.com, if you're a subscriber, we send out the schedule whenever I'm going to do a show. And this is not a planned one. I'm here with my friend Snoopy and my friend and colleague, Dr. Matt Lederman, because I just received an update on my cancer treatment plan. And I like to keep you posted with things as they happen. And it just happened today, right after the show. The doctor called me and wanted to Zoom and tell me what was going on, which I'm going to tell you. But before I do, and before I introduce Dr. Lederman back on the show, I just want to thank Brooke McGowan from the Plant Nutrition Project for this wonderful Snoopy. I love Snoopy. My first dog was a beagle named Snoopy. So I will take this with me if I do get treatment to the infusion center for sure. And I want to thank Nancy Matthews for this purple bottle. It's actually for hot. I don't know if it's from the cancer or just because I live in Northern California, but I'm always cold. So this is actually for hot tea and it's beautiful and fabulous. So thank you. So here we are again. Hi, Dr. Matt Letterman. How are you?
Hello, hello. How are you?
Yeah, good. So, we've been getting a lot of questions and specifically about, well, why didn't I, I shouldn't be listening to you or Dr. McDougall. I should have had treatment already when it was minimally invasive. So you're going to speak to that a little bit about the cancer treatments in general, like when they work, why they work, how they work, and when they don't. But before you give us what could be for some people very technical medical information, we're just going to tell people an update as to where I am. And nothing is 100% for sure until you actually do it. But I did get approved for some actual conventional cancer treatment. My insurance company denied it. Oh, what a big surprise. I only pay them $3,300 a month for a private insurance, and they've been denying things for the last 3 years. So it's no wonder why they would deny this. But my oncologist did what was called a peer-to-peer, like when the doctor he talks to doctor. It's funny because Matt, I don't know if you like spend any time with AI, but the denial was written like there's no way a human would have written it. Do you know what I'm trying to say? It's almost like I was denied by artificial intelligence because when they dropped it in the chart, there's no way a human would write or talk like that. But I
Right.
guess apparently when a doctor goes to a doctor for these peer reviews, they can often be successful. So she was. And so I can tell you what was offered and what I'm thinking of doing. But then she threw a little wrench in it today when she offered me something else that was approved. So originally, what was offered was the trifecta of the the standard of care, which is chemo, radiation, and surgery. And I did not want any of those for lots of reasons, which I've said on previous videos. But what people aren't understanding that even though my tumor was smaller, it was never going to be just taking the tumor out. It was always going to be a complete left lower lobe lobectomy because of the proximity less than 2 millimeters to the aorta. They couldn't get clean margins. And while I could still have that operation, even though I do have a met in the lymph node, and I guess they take that out too, I didn't want that operation because I have COPD and also because I've had allergic reactions to general anesthesia where I stopped breathing. So I never wanted that. But I have been offered once again radiation therapy in conjunction with chemo. I think the chemo would have gone first. And that didn't sound so good either. So, as you know, if you watch this show regularly, Dr. William Lee, who is a very, very smart cancer research doctor from Angiogenesis Foundation, he talked about something called immunotherapy, specifically Keytruda. And it turned out that my tumor was 85% P. There's a number, strong match for that. And so I I agreed to that. She wants to do it for 2 months. So that's 8 treatments every 3 weeks. I had my little training, my patient training, and I got to go take a tour of the infusion center and sign my life away about all the potential side effects. So I understand that it is not without risk, but talking to many people that have had immunotherapy, a lot of them have had really good results from it. And it seems that although there can be side effects that are unpleasant, not everyone has them. And it seems to be a lot more gentle than chemotherapy in terms of the experience and especially with long-term side effects. And so we need to get what's called a baseline PET scan first, just to see if anything has changed since October, because, cancer is unpredictable. It could have grown, it could have spread. I mean, my hope is that it shrinks and goes away. So they can't do that until the 25th of January, which means that it takes about 2 days for the results to come back. And then I could ostensibly start cancer treatment either the last week of January or the first week of February. But then she told me something that Dr. Lederman is going to have to explain to you, because this is brand new to me, that I could choose, instead of the immunotherapy, a drug called Tabrecta. These is targeted therapy. It's not chemotherapy. These are oral medications which you take every day. And apparently they do have side effects, but it's not as toxic as chemo. It's CAPMATINIB, capmatinib is what it is, and then the Tabrecta is I guess the name that they sell it under. And I said I would need to look it up and find out a little bit more about it and ask people in my cancer support groups if anybody has taken it. But apparently it's matches my mutation, whatever that means. I don't know anything about this. So I was doing really well, but every time I see the oncologist, she puts my head in it's not her personally. It's not her as a person. It's just the whole profession of oncology. I think I'm doing really good. And then they start talking about the things they talk about and like, oh, no, it's too late. We can't cure this now. And blah, blah, the rest of your, blah, blah. I just kind of like get a little bit scared. So anyway, how are you, Matt? We're going to Disneyland next week. Let's just focus
Um,
on that.
I'm doing well, AJ. It's a whirlwind out there. It's a lot to take in, and it's hard. If there was something that worked really, really well, there wouldn't be so much confusion and choice. They would just say this works really well, and there's uh, the language they use is sometimes confusing and misleading, in my opinion. And I can give you an example of that. Would you like an example of that?
Absolutely.
So you're looking at the Keytruda, and the doctors say, well, we do Keytruda with chemotherapy because it works better in combination. And then you go and look at the studies, and what I can find is Keytruda plus chemo versus chemo alone. So basically, what happens is when you take chemo and you add Keytruda, that works better than chemo alone. So then they'll say the combination of chemo and Keytruda works better. But if you look for Keytruda alone, which there is some studies on doing it alone, they don't have anything where they add chemo and show that it works better than doing the Keytruda alone. So do you see how that's confusing, AJ, where they'll say it works better in combination, but
Mhm.
it's not the combination, it's not what you're looking for, the information. And I think that the studies are done really well to sell drugs, and they're not done as well to help patients make the most informed decision. Because if there was a study that looked at Keytruda alone versus adding chemo or adding radiation, and it said, hey, you live longer when you add chemo and radiation versus Keytruda alone, you would have the information you need. That doesn't exist. And when we ask for it, the doctors confirm that doesn't exist. So they're doing the best they can with the information they have. And that's challenging.
Yeah. So,
So so
yeah.
what do you think when you hear that, AJ?
Well, I think it just makes you more confused, and also it makes me confused when she says things like, "Oh yeah, well this is still curable," and then at other times she says, "Well now it isn't curable." I mean, is cancer even curable? Like, I guess would be my
Well,
question.
that's a good question. So all cancer is not the same. I'm going to share my screen to show you something. And John McDougall, I get pretty protective and defensive for him. I mean, he's one of the smartest people, extremely well read. And he's a guy that when you would ask him about a study, he could tell you what page the information that he's talking about, what page of the study it was on. Most people talk about studies, but they don't really have that type of information or they don't have that background. So he knew this stuff inside and out, and he was very specific about make sure you read these articles. And a lot of the articles, there's some that are older, and people say, oh, those are older, those don't matter as much. When in fact, those are the ones that actually answer the questions, and the new ones are really focused on selling drugs. So don't discard older articles just because of the date. See what they're studying and use that to determine if it's valid or not. Here's the one I want to show you that this is one of McDougall's was one of his favorites. Let's see if I can find that. Oops. All right. Can you see this here?
Yes,
This
screen.
graph?
Mm-hmm.
Okay. So you can see this graph right now?
Yep.
Okay. So AJ, I want you to look at this. And I want you to look at, you see how there's these tumors that start off here. And this was an article looking at cancer screening. But one of the challenges here is you see how there's a tumor A that goes in this microscopic area and it never leaves the microscopic area, meaning if you didn't look for it, you would never know you had it. There's a tumor B, which goes and it's localized to the organ, but it never goes to even regional spread. There's a tumor C that grows and it grows slow enough. You see how the line, this is sort of how quickly it progresses. And then eventually it goes regional and then it metastasizes. And then there's a D, which basically has almost no time. It's just flying up to metastatic spread. So tumors C and D are the ones that are potentially lethal or lethal. Tumors A and B are not. All of these cancers start and go through the stages. So stage 1, stage 2, stage 3, stage 4. You don't know if you have an A, B, C, or D type of tumor until it presents itself. But by looking at it alone, you cannot tell. So when McDougall said you have the tumor in your lung, it's localized to the organ there. He said, let's see what happens, because he was basically saying if it's tumor B and you get treatment, there was no reason. Now, here's the challenge is a lot of people with tumors B, or if they pick up a tumor A on screening, AJ, and then they get chemo and radiation surgery, they all think they survived because of the chemo, radiation, and surgery. When in fact, tumors, if you had tumor type A or B and you got chemo, radiation, it didn't save you. In fact, you got treated unnecessarily and dealt with all the side effects of those treatments unnecessarily. So McDougall is trying to figure out, do you have A, B, C, or D? We don't have good tools to be able to determine that early on. Now, people say, well, why don't you just take it out to be safe? Let's assume everything is tumor, C, and then let's just take everything out. And that's how the industry practices. Now, here's the next slide I'm going to show you. All right, here. Tell me if you can see this. All
Yeah.
right, hold on. All right.
Not yet.
Can you see this?
Yeah. TVDT.
Yeah, TB. Okay, so that is tumor variable doubling time. And this is so important, but it's hard to understand that if you get it, great. But if not, we can talk about it again another time. This is showing these three lines. There's a dark sort of light line and then a darker line here. These are three different tumors. And you can see the TVD right here. You see how the one on the left has a doubling time of 10 days. The one in the middle has a doubling time here of 100 days. And the one on the right here has a doubling time of 150 days. So what do I mean, AJ, by doubling time? I mean that a cancer starts as one cell, then it doubles to 2, and then 4, and then 8, and then 16. And each one of those doublings has a relatively consistent doubling time. Now it can change, but in general, according, these studies show that it's relatively consistent, which means to go from one cell to two cells, if you have a doubling time of 150 days, it takes about half a year to go from 1 to 2, and then takes another half a year to go from 2 to 4, and then another half a year to go from 4 to 8. Does that make sense so far?
I think so. Yeah.
Okay. So now what McDougall knew that a lot of people don't understand is that cancer has to double approximately 25 to 30 times before it gets to this area right here. This blue area here is when it's detectable. This whole area where there's this green arrow here, it's not detectable. Okay? So when cancer is 0.2, which is 2 millimeters to 1 centimeter, so 0.2 centimeters to 1 centimeter, that's when it's big enough that we can see it with our scans. To get to be that big, it's got to double 25 to 30 times, which means that a cancer that is, let's say on average, is about 10 to 15 years old. Let's say 10 years. It's about 10 years old by the time we can detect it on our scans. Does that make sense? In other words, it has to double and get to be over a million. It's got to be almost closer to 10 million to a billion cells big. That's when we see it on our scan. That's when we can say you have cancer, AJ. Before that, you're not going to be able to see it. We're going to say you don't have cancer. But what you could have is something growing slower and smaller. So now, AJ, when you look at that tumor and you say, oh, well, we should cut it out. Well, here's the other kicker. That if you have the kind that's going to spread, it's spreading when it's in million cells, 20 divisions, 0.1 centimeters. It's spreading before you can see it. And McDougall knew this. So the part of the cancer that's going to kill somebody is not the local tumor, it's the stuff that spreads everywhere else. So what he knows, and it's hard for people to be okay with this, is that if you have that type C or type D cancer, the kind that's going to spread and metastasize, it's spreading around year 6, even though you don't know you have cancer till year 10 when it's big enough to see it. But there's been spread that's been happening for 4 years under the radar. So McDougall knew that if you have tumors A or B, the kind that weren't going to spread, doing chemoradiation and surgery were not helpful. He also knew that if you had cancer that was going to spread, it spread 4 years before you found the cancer. So doing surgery and radiation can't stop the spread. So surgery is going to cut out the local tumor. It does nothing for the spread. Radiation attacks the local tumor. It does nothing for the spread. So people will say, why don't you do chemo? Now I'm going to show you why he didn't like chemo and why I don't recommend chemo for many cancers, not all of them, but I'll show you in a second. But if you look at this, what they find is that cancers double, 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 and then eventually they get to something called lethal burden, which is 1 to 10 trillion cells. That's 40 plus doubling times. So cancer, by the time we can see it, is pretty far along in its life cycle. But that's why he was telling you it's slow. It takes time to get to even big enough to be able to see it. So I'm going to show you another slide here. This is the one about chemo. So people would say, well, why don't you get chemo? And here it is. Hold on a second. All right. So this was a study that looked at chemo and 5-year survival. And it looked at 5-year survival. It had Australia, which the numbers were actually worse in Australia, but I'll look at the US. And if you look at lung cancer here, it was about 2% of people had their absolute number of people that made it to 5 years because of chemo. That's what they were looking at. And what this study showed was that 2% of people make it to 5 years due to chemotherapy. In other words, chemotherapy has very little impact. And that's why I tell people there's toxicity, but if this is something that works for you, there may be some benefit. But it's not this amazing benefit. 2% benefit, 5-year survival means that 98 out of 100 people that take chemotherapy for lung cancer are not going to have their 5-year survival as a result of that. So chemotherapy, if you look at this, the overall chemo was about 2.1%. Sorry, let me go down here. There's some cancers like testicular cancer and Hodgkin's disease where chemotherapy is significantly better. You can see here for testicular cancer, for example, it's 41.8%. Now that's a group that chemotherapy clearly has a benefit in. So what I'm trying to explain to you, AJ, is that, and I want the people to understand this, is that traditional treatments, I'm not talking about the new ones, immunotherapy and these therapies that target mutations, that's a whole new class. But traditional, conventional chemotherapy works, I would say, poorly at best, and there's a whole host of toxic side effects. Radiation and surgery have not been shown to make people live longer. And the thought is, well, kill that primary tumor before it spreads, and you get it early and it doesn't spread. But what the studies show is that if you have the kind that's going to spread, it's already spread. And all these people that got surgery and radiation to the primary early stage, and they said, oh, thank God I got it, the data shows that they likely had a cancer that was not going to spread, not that they got it before it spread. Now, I'm not saying that's 100%, but that's what the odds are, and significantly so. So I'm going to stop there and see if you have any questions about that, because it's off-putting to a lot of people when you tell them that a significant portion of people, especially if it's screen detected, which is why there's a whole issue, Gilbert H. Gilbert Welch, screen detected cancer is going to find more of those tumors A and B, because those are the ones that are not growing fast that we can see. And that if you treat those, you're treating them unnecessarily, and people are getting treated unnecessarily and exposed to those side effects unnecessarily. Now, how do you feel when I tell you that? Is that confusing? Is that upsetting? Is that enlightening? Where are you?
I don't know. I mean, Dr. McDougall did his best to explain this to me, that it had to have been there a long time, but it's still scary when you jump from stage 1 to 3 and now are told you have a MET, but I guess that MET was always there and it just wasn't visible.
No, what I would say is it's very scary, and that no, the MET wasn't necessarily always there, but you had the kind of cancer that was going to spread. We didn't know that early on. And if you have the kind that's going to spread, conventional treatments like radiation, surgery, and chemo are not going to cure that. They're too toxic and they're too ineffective. So every cancer that grows and even if it's growing slowly, if it's going to, and that's the other thing, is that you're doubling time, we can slow that down. There's with diet and lifestyle and other things, in theory, they can slow down the doubling time. So even if you have a kind that is spreading, you can slow that process down. So AJ, if you have the kind that's spreading, whether it's doubling every 10 days or doubling every 200 days, you don't know which yours is. Well, we know it's not 10 days, otherwise that would have shown up faster. But you don't know if yours is 150 days or 300 days or longer. And whether it's 150 days, which means it's going to double faster, or 300 days, double slower, as it's growing, and it's going to go through stage 1, stage 2. So a stage 2 cancer can be one that's doubling at 150 days. It could, depending on when you catch it, it could be doubling at 10 days, or it could be doubling at 300 days. So all stage 2 cancers are not the same. Stage 2 is almost like a snapshot in time. But as far as how the tumor works, that could be doubling faster or slower. We don't know. Then you bring in immunotherapies and these therapies that attack mutations. Now you have something that's targeted, because chemotherapy is too toxic to all of your normal cells and not toxic enough to all the cancer cells. If you take an immunotherapy or these targeted therapies, that is less toxic to your body and more targeted to the cancer, which is why we're excited about those.
But they're not curative.
See, that I don't agree with that. I think the fact that she's telling you, if anything, she's telling you about the curative abilities of surgery, radiation, and chemo, I believe you have the same chances, probably better, with doing your diet and lifestyle changes and including immunotherapy and drugs like Avastin, the angiogenesis inhibitors, and then you have this targeted mutation drugs. To me, I believe you're not only can it be curative, but you're going to do less harm to your body. Like, the radiation doctor told you that it's going to hit your heart, even if he tries not to. We know chemotherapy hurts different parts of the body. And a lot of the people that do make it 5 years plus, because with chemo and radiation, they're dealing with the toxicities and they struggle with years 5 to 10 and longer. So I think you got to take all that into account. And if you understand that, then it makes the decisions a little easier. But to knock somebody like McDougall is, to me, demonstrating that you don't understand how this works, not that McDougall did anything wrong.
So people seem to believe that if I had had the tumor removed immediately, like 2 years ago when they found it, and it was 14 millimeters, it wouldn't have spread. But if I understand you correctly, that's not true. It still could have spread and
Yes,
metastasized.
because think of it as person A, B, and C. Person A has that tumor A type we talked about. B, he found it screening. Tumor B, and then there's tumor C and D. All of them go through stage one when you were talking to McDougall. All of them go through stage one. It just depends if you catch them. Now, if they're stage one and you have tumor A or B, you could get the surgery or you could not get the surgery. And either way, you're going to survive. So all the people with tumor, all those people like person A and person B who got surgery, chemoradiation, survived and said, see, this was a good thing that I did that. And what I'm saying is, it's actually a bad thing because you would have survived without the treatment. Now people are going to go, I don't want people writing in and saying, oh, I'm telling them getting treated is bad. I'm saying that you don't know if you're tumor A, B, C, or D. That's the problem. But you do know that if you're A or B, it's not going to kill you. And if you're C or D, it's already spread before you found it. So the horse is out of the barn. So our job then is to try and slow the doubling time down and not expose you to the therapies that are quite toxic and actually damage the immune system that is your natural cancer fight.
Yeah.
So does that make sense, AJ, that it's the people that are telling you at stage one to get this removed, it's so unlikely. I'm not saying it's impossible. And if you want to bet, and even though if the odds are low at stage one, that you have the kind that's going to spread and kill you because of the spread, but you think you got it before it spread, so pull it out now. It's so unlikely to be in that window. It's more likely that it either already spread or it's not going to spread or it's spreading so slowly that it's not going to kill you anyway. The odds are much bigger that one of those choices. Now, that's why McDougall gave you the choice too. If you wanted to say, hey, I'm doing everything, I don't care, even if it's a 1 in a million chance, I'm going to do it. I think that's where I step back and say, okay, you have the information, now do what works best for you. Does that make sense?
As much as it can to a layperson that's a nervous wreck. But I
Yeah.
will definitely watch it again. I guess I just am confused about the Met because I feel like, that maybe if I had done this, see, I was so afraid to do the surgery, and they were going to do the surgery without even a biopsy. Like I thought that was kind of weird that you remove somebody's left lower lobe and then check right then if it's cancer. You know what I mean?
Yeah. Yeah. My understanding is they usually get the biopsy first, but maybe
It
because
was
of the
so
liquid biopsy, they were,
it was too small to biopsy at that point, the
oh, is
radiologist
it that's
said.
that when they're
Well,
talking
he
about? Yeah.
said, he said it would have been really, really difficult to get it at 14 millimeters. He got it I guess, what is it, 21 now, or maybe it's 27, depending on which way you look at it. But why, I'm confused why the Met turned up in this. It didn't turn up, they didn't see it on the CAT scan that was in October 1st, but on the PET scan, it showed up.
Yeah. So you have cancer that's spread, and we're going to get the next PET scan coming up. So you have a kind that's spread, but we don't know how fast it's spreading. But we do know that when your cell was 1.4 centimeters, that's when you saw it. It was over 1 billion cells. And it started spreading when it was 1 millimeter, and it was now 14 millimeters, which means multiple doubling times. So from 1 to 2 to 4 to 8 to 16 millimeters. So 2, 4, 8, 16. So at least 4 to 5 doublings. It was spreading before that. So does that make sense? But do you see how if somebody has a cancer that's 10 years old when they found it, it started spreading at year 6. So the stuff that spread when you find your cancer at year 10, the stuff that spread is only 4 years old. Does that make sense?
Yeah.
And that stuff that spread as 4 years old, it needs to go another 6 years before it's going to be big enough to see it. So what do we call that stuff? when we see it 6 years later, they call that a recurrence. But that's not really a recurrence. That's stuff that spread that you couldn't see. It took 6 more years to see it. Does that make sense?
Yeah, I'm going to have to watch this again to see if it makes sense, because what I don't understand is I had the true blood tests because I couldn't get the biopsy or even an oncologist. And if they could find cancer in the blood, didn't that mean it was already spreading?
Well, when you got it, when you got the cancer markers, it was already 1 point. It was big enough that if it was, spreading.
And I also,
So,
yeah.
right, because you got it shortly. What got you? You did the first scan. You found it by accident, right?
Yeah, well, so what was found by accident in the summer of 2022 were 4 millimeter spots on both the lung and the liver, not the primary tumor that started out, or at least that we first visualized at 14 millimeters.
So
These are other tumors.
the the two spots that you found early, those were no longer existent,
They're still there, but they haven't changed in size. They're still about 4 millimeters. I have other spots on my lung and liver that are 4 millimeters.
and those aren't growing.
Those are not growing, not
Yeah.
since
So your
October.
body is dealing with those. And there's this that is grown and it's spread a little bit. But to your point, it spread, but they couldn't even see it on the CAT scan. They just saw it on the PET scan. They saw the metabolic activity.
Yeah, they didn't see the Met on the cat. All
Yeah.
these, all these
All
abbreviations.
these abbreviations. So I, it's clear that you have something that that is spreading. How fast that's all happening is not clear, but it's clearly not happening super fast.
Yeah,
And you're doing things to slow it down, and you're exploring these targeted therapies that can actually attack the cancer without hurting your body as much. There's still side effects and risks, as you know, but it appears to be much more effective, particularly with the histology that you have, which is good news, and less likely to hurt the rest of your body.
yeah. I'm still in the process of trying to find more people that have done immunotherapy, but in my limited research so far, they don't seem to have like long-term side effects the way with, I mean, some might, but like, you know how a lot of times people with chemo, they get that permanent neuropathy, for example, and I'm not seeing that, at least in the people I've talked to, and they said it was definitely a much easier experience. And it's only a 25-minute infusion. So, you're not there for hours and hours. And so,
Yeah, and
yeah,
it sounds like the doctor is now more open to trying to find something that works for you versus forcing you to be in the same box as everybody else.
I feel like when I said to her, you've been asking me to get treatment for 2 years and now I'm agreeing. So isn't it better that I do this than do nothing? And what are they going to say? Of course they said yes. But then I had already psychologically committed to doing this. And then she threw me for a loop today when she offered me this targeted drug, which honestly, I haven't had a chance to check out to see if that
Yeah,
would.
and that's what we're gonna do together is look at this drug, see what the data is, and see the impact, just like we did with the Keytruda, and then you'll be able to make an informed decision.
Yeah. Yeah. It's just,
It's so overwhelming, and it's hard to take in education when your brain is sort of overwhelmed by all this stuff, and there's emotions flowing, and that's what makes it really challenging. That's why it's so helpful to have someone like John McDougall who you trust, and just say, "Hey, help me figure this out." That's when we had some health issues. My logical brain turns off, particularly with my daughter. And McDougall was there to just sort of help, because I almost did surgery on my daughter unnecessarily, because all the children's doctors, the quote unquote best experts, were telling us, you have to, this is what everybody does. This is standard therapy. And it wasn't until I connected with somebody in the UK who was an expert in this that said, even our most aggressive surgeons wouldn't do surgery on your daughter. And he said, don't do anything. And he said, stop doing scans. So there's many different doctors out there and ways that they practice, and it's very easy to second guess people and do sort of this Monday morning quarterback stuff. But at the time when you had a single tumor and it wasn't clear if it was the kind that was going to spread and it wasn't growing very quickly, to hold off and know that if you have the kind that's going to spread, it's already spread. And if you have the kind that's not going to spread, you're not doing anything anyway.
And I want
And now
people
that
to
you know
know.
that you have the kind that's going to spread a little bit, now we're exploring treatments that are maximally targeted to kill the tumor and minimally harmful to your body. And that's what we're figuring out right now.
And I want people to know that I didn't seek treatment early on because I was listening to Dr. McDougall. He just happened to say what I wanted to hear. In other words, I didn't want it even before I ever told him. And so
Right.
it just was somebody that was just saying, hey, you don't have to do this. The thing that's so hard is, that, as you know, there's no guarantees in medicine, just like there's no guarantees in life. And I just would feel terrible if I go through all this time and energy and possible feeling bad for long periods of time and then it doesn't work, then I would have said to
Yes.
then I'm going to be more upset with myself saying I should have just done what Dr. McDougall said, which is he said, walk away, don't go to any more doctors, no more scans, and just enjoy your life. That's what
Yeah.
they told me to do. And that's what I'm
Well,
kind of trying to do intermittently. In other words, I mean, I'm, I'm
well,
enjoying my life intermittently because we're going to Disneyland, we're doing improv comedy. So I do have large pockets of life that I'm enjoying, but it's like this, it,
it's so much.
it's the part that's overwhelming. It's kind of like, I mean, I don't know what this is like because I've never been on death row, but it's like how do you enjoy your last meal, when
Yeah.
it's, you
It's
know,
it. It's tough. It's so hard.
it's
It's
really
so hard.
hard.
It's so
It's
much.
so hard
It's
because
so hard.
you
And I
just don't,
think,
and then people, God, they're so, vegans especially, they're still so judgy. Like the stuff they say, it's just so unkind. Because, like, I mean, how much more can I improve my diet, guys? And people are saying we should try to fast again, gain some weight so you can fast again. Even Dr. Goldhammer will tell you not everybody can respond with, that, I mean, even though there's people that have fasted and shrunk tumors, that doesn't mean it's going to be me. And I'm never seem to be able to fast long enough really to affect, any kind of
yeah,
change. But I feel good about immunotherapy because I know that Dr. Goldhammer is pretty much against almost every kind of medicine. And you were on the call with Dr. Sultana, who said that they've had patients at True North that have had great success with immunotherapy
yeah,
in their cancers.
yeah. I have a distant family member who treated lung cancer with immunotherapy and has been doing really well. So, and that's what I think is also important is that McDougall, me, I want this to be very clear. No one is saying this is what you have to do, AJ. People are giving you information and then trying to support you to do what works best for you. And I hope that people hear that clearly that everybody ideally is supporting AJ doing what works best for AJ and not telling AJ what she should do, what she should have done, but saying, hey, this is what worked best for you. And we're doing our best. And you know how many people, AJ, McDougall had a close family member who had cancer and, quote unquote, did everything. They wouldn't listen to McDougall and they got all the treatments and they died anyway. And they had tons of medical bills and they were spending all their time getting treatments and they felt terrible and it was miserable. But because they got all the treatments, nobody judged them and they felt okay because they didn't do nothing. And it takes a lot of courage to go outside the box a little bit. And I think what you're doing, AJ, is quite brave. You're taking all the information and you're not blindly saying, I'm not getting anything at all. And you're not blindly saying, do whatever you want to me. But you're thinking it through and you're getting a lot of counsel. We're talking to a lot of different experts, a lot of smart people. It's not just us. There's a lot of people smarter than both of us that are helping us out and you're doing what works best for you. And I really hope that people don't judge you or don't judge John McDougall. And it's if until you're in their shoes and know what they know, it's better to refrain from judgment.
Well, also because I can't do everything because if I do nothing, somebody's going to be pissed off, and hopefully it's not My brother, who's at least he's happy now. He's a medical doctor, and it's like, why didn't you do anything? At least I feel like sometimes you just get treatment to treat your anxiety, not so much the cancer, because
Yeah.
like, kind of like boiling water when somebody's having a baby, it doesn't really do much except that it gives you something to do. So you feel like you're doing something. But I feel from what I know about immunotherapy is that it doesn't, I don't think it's going to make the cancer worse. That's my understanding. It's not like it's doing something that's going to cause, if it's going to grow and metastasize, it's not going to be because I did immunotherapy.
Right. Yeah. There's not, I mean, I don't believe any of these interventions. I mean, surgery just short of dropping the tumor and, spreading it around your lung cavity, even, all of those treatments are going to, um, I don't see them making things worse. The side effects might make things worse, but in your overall well-being and health. And radiation, I'm not completely against radiation. There's a time and a place. I think it's really good for palliation. It definitely will shrink tumors. Chemo will shrink tumors sometimes. But just that's why it's very important to look at overall survival in these studies. Just because you've shrunk the tumor or you've changed the progression-free survival or you changed the response rate doesn't mean it changes the overall survival numbers. And that's where it's also misleading in the studies because they'll look at these outcomes that don't really talk about overall survival. And many do. Usually they're secondary endpoints. But it's hard for them to affect overall survival, so they're looking at these other things.
Yeah. Somebody on Instagram saying, do it in a holistic way that supports your immune system. My understanding is that immunotherapy did that, which is what chemo doesn't do. Also, the holistic places, and believe me, if people knew how many interviews and phone calls I've had with so many places that treat cancer in the United States and even out of the country, all the holistic places, they do not take your insurance at all. And so we're talking like we're starting like 50 to $80,000 just to go there for a few weeks. And in a few,
Mhm.
and that's for the first visit. And so I have to think about my husband's future. I don't want to break the bank. I mean, the good thing about conventional treatments is they're covered by insurance by and large, and I pay a lot of
Yeah,
money for my insurance. So believe me, I'd love to go to these places in Mexico and Germany, but I'm not going to break the bank to do that, especially when they can't really give me evidence that they've had success with my particular cancer. There was one person on their website that was 26 years old, with lung cancer, you know. So
yeah,
that's not enough of a proof to me that you're going to be able to help me though. But what's interesting is the Dr. Neil Nedley, who's my primary doctor here in Northern California. He runs several programs at Weimar, including the New Start program and the Depression Anxiety program. And he's going to be on the show Thursday. We actually pre-recorded it because we're going to be at Disneyland. And his whole talk is about how depression and anxiety, but especially anxiety, suppress the immune system and makes it more difficult to heal in general, but for cancer specifically. And that was a very eye-opening talk, something I had never heard before.
yeah. I'm so glad that more and more people are talking about the impact of particularly toxic stress. Not all stress is bad, but toxic levels of stress, how you respond to it, depression, anxiety. Again, a little bit of anxiety at the appropriate times is not a problem, but chronic or extensive can be quite harmful to your health. And we've shown that that affects there's a guy at UCLA that talks about this CTRA, conserved transcriptional response to adversity, and how your immune system genes express themselves. And the response affects your ability to fight cancer, inflammation, it affects metastases, and um, all sorts of things like disconnection, lack of meaning and purpose, anything, increased fight or flight, chronic stress type of responses. All of that affects that pathway, those pathways. So it's so important. I hope people take it seriously, and there's a lot more to do than either chemotherapy, surgery, and radiation, or nothing. You're doing a lot of stuff, and I think you're balancing all of this.
Yeah. Well, I'm looking into his program too because I could take it in between infusion treatments, and it's a 10-day program, and it's close to me, and if it works, that would be amazing. I mean, he seems to really think that if you get to the root cause of anxiety with the treatments that they do, and they do all kinds of things, it's not just mental therapy. They do, something called hot and cold. I'm not sure how that helps. But I do know that was one thing she said, don't get too hot and don't get too cold. And I'm always too cold. So we'll see how that's. I live up here. Yeah.
Oh my goodness, it's and I think there's so much benefit to your health, and including these pathways we just talked about, understanding these emotions that we're not in contact with, we'll sometimes suppress, whether it's anger, rage, depression, a lot shame. There's all of these emotions that doing that healing work is so important, and I can only see it helping.
Mhm.
I can only see it helping.
I agree. It's interesting because I'm going to be having some of these organizations, these nonprofit organizations on the show this month. One is called Immerman's Angels and one is called Go to Lung Cancer. And they do a lot of things in the cancer space, but one of the things they do is they pair people up with mentors with their particular cancer, kind of like a buddy, And so I'm talking to more and more people because I've been in a space of, just don't take, for the longest time, no medicine, all medicine's bad and all procedures are bad. So that's the world I've been living in. But there's a whole nother world up there of, allopathic medicine. And I'm talking to people that are survivors, and I mean long-term survivors that have done all the standards of care and they are still alive. And yes, some of them have those long-term side effects, but whenever I talk to anybody that's still alive, guess what? They are happy that they're still alive. You know what I'm saying? Like they would
Yeah.
rather be alive with neuropathy than dead without it.
Yes. And this is the challenge, AJ, is that if you're just looking at the data, it is not clear until you have the kind. I mean, I don't want to keep going back and sort of harping on it, but the challenge is if they had type those tumors type A or B and got treated, they got treated unnecessarily. If they had types C or D, they it was likely, there's a lot of people that get treated and don't survive. You know those stories too. So I don't want to give all this credit to the treatment and then sort of look the other way when the treatment doesn't work. Because how many times do we know of people that did all of the treatments and it didn't help them? So my point there, AJ, is don't let that push you to do something you're not comfortable with. It's not as clear cut that if they're alive, it's because of the treatment, and if they died, it's because they didn't get treatment, or it was unfortunate that the treatment didn't happen to work in them. That's not. I don't think that's a fair way to look at what's happening. And I think if you do look at it that way, it's going to push you to do something you might not be comfortable with.
Yeah. Well, I mean, if I won't meet these people probably because they're probably not in the groups, and like you say, I'm sure they exist. So, the whole thing about this whole thing about targeted therapy with this medication, do you understand any of that? What the mute this mutation, why the oncologist feels this oral medication now would be even maybe better to do than Keytruda? Because apparently I have to choose. I can't do both. I could do Keytruda and then go on that oral medication, but I can't do both, at least not at the same time.
You have to find out because I don't know a lot about the Tabrecta, so I want to that you just heard that from her. This is the first time I'm hearing of that. So I would definitely want to do more searching around what the data is on that. We did a pretty extensive one on Keytruda data. There's not a lot. It's usually added to conventional treatment and it enhances the conventional treatment. But there is studies of looking at Keytruda um, versus, I believe, well, there's definitely studies looking at it alone, and it's beneficial. And but it's usually people that wouldn't tolerate all the conventional stuff because it was so hard on their bodies. So like I said, the data is, we're doing the best to interpret the data and apply it. But both of those, when they're targeted and the side effect profile, I would want to pick one that's, um, I'd want to find out from her the downside of combining them. Now, she sounds like she's open to doing them consecutive. So you could do one and then the other, and that would probably decrease side effects. And then there's also, we talked about, which we were talking about with Dr. Lee, the Avastin. I don't know if she mentioned anything about that. So we just have to try, and that's the other thing, right? It's so hard to get everybody together. Wouldn't it be great if we could talk and William Lee could be there and your oncologist could be there and everybody could put their heads together and get a clear plan with you. But instead, you're trying to go to each person and gather, and then it's a he said, she said, and you're going back and forth, which makes it exhausting.
Yeah. Well, would you like to answer some questions from some of the live viewers that are typing them in the chat?
Yes.
Okay, so Deborah says, my husband has stage 4 lung cancer. It's not changed in 3 years. The tumors are not bigger, not smaller. Does that mean it's just growing smaller? He's on a targeted drug, no surgery, chemo, or radiation.
So he's on a targeted therapy for his lung cancer?
Yeah, I could get you the name of the drug if you wanted. It's
Yeah,
called
I mean, I'm not, I don't, I'm not,
Tagrisso. Yeah.
yeah, and I'm not a cancer specialist. My specialty is helping people understand studies and interpret studies and communicate with doctors and helping them take in all this information and figure out what really works best for them when they're feeling so overwhelmed and emotional and and helping them navigate this whole process. So I don't want to be answering questions and implying that I'm an expert in oncology medications, for example. Um, but each person, in theory, has all the analyses, the histology done to identify what targeted therapy works best for them. And I'm a big fan of targeted therapies over the sort of general sledgehammer of a chemotherapy. So it sounds like this is working for him or for this viewer's husband. It sounds like it's working and it's not even slowed things down. It's stopped them to a halt.
Yeah. Okay, more questions. Do. This is from Faith. Any thoughts about metformin and cancer? I've read some research that it helps.
And metformin seems to be everybody's talking about metformin and it makes you live longer and it does all sorts of things. I don't know data showing that it's an effective cancer treatment. Can it have some anti-cancer properties that help helping keep blood sugar and helping the immune system function better? But I would assume why not improve your insulin resistance with diet and lifestyle as the primary method of dealing with the problem. If there's other studies, we're happy to look at them. And I think if anybody has studies, people did send studies and from past shows and we've looked at them and it didn't actually show what we were wanting to look at or it's studies that we're aware of. But please send the links to studies if you think they'll be helpful and we'll be happy to look at them.
Yes, thank you. And here's a question from the comeback doc. Do you think chemotherapy is effective for NH lymphoma B cell?
Yeah, see, this is those where we can look at, for example, specific data recently on the lymphoma, for example. But you know, the study that I pulled up looking at chemotherapy impact on 5 year survival just due to chemotherapy for like a non-Hodgkin's lymphoma, it was 10.5%. So that's where the odds are starting to go up. Now it's a 1 in 10 chance that chemo is going to help with getting someone to 5 years survival. So that's knowing that, then they have to decide if that's worth it to them. But there might be, I'm not an expert on all the cancers. Like I said, I will, when I have a patient that has cancer, and then we look at the data and we talk to the specialists and we figure out what that says, and then we make a plan that works for them. So each cancer, each situation, I'll look at individually.
Mm. Well, is there a point after which if you've survived a certain amount of time that you can declare yourself cancer free?
Well, they call you cured if you make it 5 years without cancer. So that's the industry standard, and that's why they look at 5 year survival.
What do you mean 5 years without cancer? I mean, like,
So
if
if
you're
they make the
if you're
cancer with,
still alive, but you have it, are you a survivor?
they will not call that cured. If you have cancer, they call, where there's no sign of, no evidence of disease, and you're alive 5 years later and there's no evidence of disease. But remember, if they make a tumor a millimeter or less, we're not going to be able to find it anyway. There might be some tumor markers, but in general, you're not going to see it on the scans if it's less than 2 millimeters. So there's no evidence of disease. I tell people everybody has cancer. This is something that I was talking about with Dr. Lee, William Lee. He talks about it the same way. We all have cancer. We all have tons of mutations happening every day, and our body's navigating that. So this idea that we're cancer free, no, we just don't have cancer that's grown or gotten big enough or started spreading, but our bodies are fighting cancer every day.
Mhm. Uh, Claudia says, if it helps you to share your treatment diagnosis with the public, that's great, but you don't have to. It's your life. Nobody else has the right to tell you what to do. I feel like my sharing has helped other people that you'll see that'll come on the show that have been hiding it as well. So I'm kind of already in too deep. So I kind of feel like I have to keep going. But if at any point I feel like I don't want to, I won't. But thank you. I appreciate that. Jeff is saying, Dr. Thomas Lodi has stated that ivermectin will kill cancer T cells and shrinks tumors. Do you have any studies that show this? I don't. I am taking ivermectin, and boys, it's messing with my vision. It's been 2 weeks now, and it's like I can't see worth. I can't see at all. I mean, I can see. Obviously, I can see, but I can't read. So if you do send me books, send them Audible because I can't read, if that makes sense. Dr. William Mackis, do you think he'd be a good guest on the show, or is he a little bit too controversial even for our audience?
Well, I am a big fan of letting anybody speak. This whole idea that they're too controversial, so we don't want them to speak. I don't like that. I like hearing what people have to say and then deciding what works for me and trusting that your audience is intelligent enough to determine what makes sense to them. But I don't believe we should ever censor or hold people back. I think we can learn. And even if we don't agree with everything that Dr. Mackis says, there could be some good learning. I mean, I looked up some of the stuff to see ivermectin and the impact, and it does appear that there's anti-cancer properties and potentially some effect on cancer pathways. And the problem is that no one's ever, if the drug companies were focused on helping patients make the best decisions, then they would study ivermectin and these other drugs. But because that's not going to make them money, they're not studying those drugs. So we don't know. And therefore, people are always going to say there's no data, so you can't do it. And I think that is closed-minded because the reason there's no data is not always because it doesn't work. Often there's no data because there's no money in it.
Hmm. Yeah, that makes sense. Well, that's about all I got. What do you think? Anything else you
Well, I
want
want to just check in. You were doing this work with Mark. You call him the unicorn.
Yeah, the Mark, the magical unicorn. Let's see, I don't think I've had a session for probably a week or 10 days because for the most part, up until today, I have felt better. I mean, he's helped my anxiety so much.
Yeah. And he's also given you skills to be able to connect with your own anxiety and support yourself. And right now, if Mark were here, only if you're comfortable,
Hmm.
but how would you apply some of the stuff? Because I do a lot of the similar work, and how would you apply? I just want the audience might enjoy seeing how you might apply some of these skills that you've cultivated. Do
Oh,
you have
I've
any
never
ability,
been,
any willingness to do?
well, it's not that I'm unwilling to do it. It's just that I've never been good yet. It like, he always says, I don't know how to self do it yet. I just really don't. I don't know how to do what he does without him at this point. I'm still Mark dependent.
You're still mark dependent.
I'm still
Well,
Mark.
do you want to try and just do a little check-in? Because the idea with anxiety or any unpleasant emotion is that you name it and you sit with it and you sort of listen to it, which could sound a little funny to some people, but you spend a little time with it and it will naturally pass and sort of start to dissolve on its own until something else happens and another emotion comes. It could be a pleasant emotion, it could be a different unpleasant emotion. And that's the way we think about feelings is they come and go minute by minute. Sometimes they last a little longer. And what keeps us stuck is that we're trying to not feel it. And that feeling is trying to get your attention about different needs and just wants some stage time. And if you give it the stage time, it will move on because it'll say, message heard, thank you for listening. We'll move on now. It might come back later, but then you just listen to it again. And that's the skill that, I mean, there's other things, but in a nutshell, how have you been as far as just sort of spending time with your anxiety versus trying to make it go away?
Oh, well, I only spend time with it when Mark's there. Otherwise, I just ignore it. I'm going to be honest. So I will commit to doing this though when he's on because we have to show what he does for people, we
Okay.
do. But
All
what
right.
I'm interested in, and we don't have to necessarily approach this right now, is he told me about the work you do, and I don't like the name of it at all, nonviolent communication, because then but I think they need a better name for it, just like they need a better name for food addiction. But he said you're a real expert in that. And he was touching on that with me at the last session, because that might help me talk to some of these doctors,
Yeah.
and,
Well,
and
we
get,
use nonviolent communication when talking to ourselves. Mark does the talks to the different parts of you, the internal family systems, and basically uses nonviolent communication to connect with them, with each of them. So when we're talking to the doctors, we could do that. I don't want to push you to do something you're not comfortable doing now. So
yeah,
I want to make sure.
I'd rather know that I'm going to do it so I could be a little bit more mentally prepared.
No problem.
Yeah.
No problem. And I appreciate you speaking up.
Even though I'm an improvisational actor at heart and usually just go with it, I just feel like I just don't know if I want to be that vulnerable right
Yeah,
now. Yeah.
no problem. And so grateful, AJ, that you speak up. And because then I feel comfortable asking, because I know you're only going to do it when you're comfortable and
Oh
you'll
yeah,
tell
no.
me when you're not.
I figure we're going to have to do it on the 31st because it's really hard to explain what Mark does if we just try to theoretically talk about it. We're going to have to show it. And maybe we
Yeah,
could get, some of the other people that I've sent to him on that show. Maybe,
yeah,
the friends of mine that are going to him regularly now, maybe one of them might be just as good as me to do it because,
yeah.
because frankly, I don't want to. At least not right now.
It's funny, right? It's funny that and I'm including myself, there's feelings that I will go way out of my way to not feel. And at the same time, if it's, for example, I was actually just talking to Mark about this morning. I could feel sadness, I could feel fear, I could feel loneliness, I could feel hurt. I don't want to feel it myself. But if I'm watching it in a movie, or even if it comes up in like a skit and improv, that's what makes it interesting. So it's not that we don't like these unpleasant feelings or conflict. It's that we don't like the feeling of them in ourselves. But we can treat it the same way, where it's almost like a movie that you're watching happen and pass through versus getting stuck or trying to make the feeling go away. And when we do nonviolent, when we use nonviolent communication with people, it's a different approach but the same goal, which is to connect to the feelings. And then it adds on a communication to other people. But it's all about connecting to the feelings and needs that are coming up inside you or inside of another person or both. So we can, at some point, we can do that. You could even play we could do role plays where you play the doctor that you've had a hard time with, and I'll show you how. I'll play you, and I'll show
Oh,
you what it looks like without nonviolent communication skills and then with skills.
Now that sounds, would you want to do that on the same episode as Mark or a different one? Because
Yeah,
that sounds very, very beneficial.
happy to, happy to.
Yeah, here's
That's
the thing. I said to Dr. Nedley, I said, well, maybe I should go through your depression anxiety program and allow you to film the whole thing. And he thought that was a great idea. And Charles thought it was a horrible idea, because he doesn't,
uh,
I also have to respect his wishes, but because part of me is just like, yeah, let's just do it. It'll help people. And then, but then, there's always going to be those few people that are just make fun of you or mean. And that's why, sometimes you just have to protect yourself. But I do love the idea of role playing. I mean, that I would even, my oncologist isn't watching this, right? So we could we could do that.
well, you'll find that's one way to find out.
Yeah.
You get a nasty, nasty message from your oncologist
I think
saying, I saw your show, AJ. But the goal is that we're not trying to be mean. We're actually trying to connect and communicate in a way that's more authentic but also very caring. Um, yeah, it's the nonviolent communication and taking that time to communicate in that way. It just feels really wonderful. And the role play, we could do that and we get to show you, it's really enlightening to see the skills, using NVC skills and not using them, seeing how they play out. I mean, that's what our podcast is all about. It's helping parents do that with their children and with each other. And it's just a new way of approaching people. It's not that complicated, actually.
well, I said to Mark, if this will help me get what I want, I'll do it. Very
All
selfishly, I
So,
said that.
so lesson number one is if the goal is to get what you want, then no matter what comes out of your mouth, it will not be nonviolent communication. But if your goal is to connect to the other person so that you can both get your needs met, that will be nonviolent
Oh
communication.
my God, that sounds so hard. Is there a book you recommend for this?
I recommend our book.
Of course, Wellness to Wonderful. Absolutely.
Wellness to Wonderful. The second half is all about applying nonviolent communication. But there's all kidding aside, Marshall Rosenberg, the creator of nonviolent communication, he wrote he wrote a book that talks about it. And we infuse nonviolent communication, whether it's working with patients or in the book or the podcast. And like all of our, I don't know, AJ, do you see our Substack articles?
Um,
The article, I'll have to send you some, but I think you'll actually like them because, again, it's taking nonviolent communication concepts and putting it into realistic situations. And I'm usually sharing where I screwed up or, you know, made a mess, and then how I got the skills back online. Or Alona does the same thing. It's not about being perfect. It's one of my favorite lines is having the courage to make a mess and the skill to clean it up.
oh my God. Is this what we're going to do while we're waiting in line at Disneyland?
Yes. No, actually, the kids want to do improv with you. They're very
Good. Well,
excited.
oh, good. Well, we'll do some really fun, like we'll just do some, basic exercises like the alphabet game. Now that'll be fun because
Oh
I
my God.
think everybody will make the lines go faster. When you were talking about you don't know if it's like tumor A, B, C, or D on that chart, Leanne wanted to know. So there's no test to know whether it's tumor A, tumor B, tumor C, tumor D, huh?
There's nothing that I know of that can tell you the actual doubling time of your tumor load, especially as it gets big enough to see if it's spread. The tumor might not, all of the additional tumor growth might not happen in the primary. It might be happening outside. They call that tumor burden, which is the overall tumor burden in your body. So it can make it hard to figure out what that is. But if people want the study that talks about this is a fantastic study. It's called On the Growth Rate of Human Malignant Tumors, Implications for Medical Decision Making. It's a review article in the Journal of Surgical Oncology. We could link to that if you want
Yeah. If you
to
if
share
you
that with
if
people.
you want to put it in the chat, then I can put it in the other chat and the show notes while I
Okay.
ask you this question from Salah. My brother has prostate cancer and decided he doesn't want the surgery and isn't going to do anything. He's trying some holistic things. What can you tell me about this?
So prostate cancer is one of those that's very clearly and often the slow kind. And if you found it on a screening test, you usually have you're more likely to have the B and the tumor A and B, the ones that are slower growing. In fact, the article I pulled up to show those graphs is all about screening. And I think it's in Hold on a second. Four types. It's actually looking at breast and prostate cancer. And the whole article is titled Rethinking Screening for Breast Cancer and Prostate Cancer. I'll put that article in the chat here. Let me do that. So you have that one. And then I'll actually put the chemotherapy one too, so people can see that one. And that's another good one. So those are the three articles that I have all of my patients read when I work with them on cancer. All right. And actually, Gregor has a couple of videos on chemotherapy as well that I think are great, and I share those with my patients as well. So remind me of, oh, prostate cancer. So prostate cancer is one of those that when you find it by screening, you usually have the kind that they always talk about you're going to die with your cancer, not because of your cancer. So with the screening for this, for example, I would not do these treatments if you have the kind that's aggressive, that's going to spread. It's already spread, and the treatments are local, so radiation and surgery, and they have quite a lot of side effects to them as far as incontinence and sexual dysfunction and other issues, depending on if you get radiation. So in general, cancers like prostate and breast specifically are very, very responsive to slowing them down with diet and lifestyle change. So that's another thing, is that you're not doing nothing. You're aggressively changing your diet and lifestyle so that you can slow down the doubling time so that you die of something else. And my dad was shocked when he had a PSA that was going up, and then he went on the whole food plant-based diet and his PSA dropped. And his urologist said, "Oh, we don't see this. Usually they just keep going up." And the PSA is antigen specific to prostate. And it's just a testament to how we can affect these cancers.
Just doing putting all those things in the chat. So, well, what's the first ride we're going to go on?
You know, Alona, when you were sharing the rides that you want, Alona's like, "Oh my God, AJ loves all the rides that I love." So I'm the one that's doing like the roller coasters and the ones that swirl you around, and those make Alona sick. But she loves the Haunted Mansion, and she loves the Pirates of the Caribbean. What was another one that you named?
Oh, well, let's see. Those are my two favorites,
Those are your
actually.
two favorites. Those are
Yeah,
two of her favorites too.
yeah. Those really are like the must do. But they have a lot of new rides now. Have you been there since they have Rise of the Resistance?
Yeah, I haven't. I've been to the one in Orlando, and it's super fun, so amazing. In fact, instead of people putting in comments about what you should do for your treatment, they should put in comments about what you should do in
What
Disneyland,
exactly? Disneyland and California Adventure. That would
California
be
Adventure.
very, very helpful. Yeah.
That would
Especially
be
because I
helpful.
haven't been there in so long, but I can't go to Disneyland without doing Pirates in the Haunted Mansion because
Oh my God, yeah, those are classic.
one of my very favorite rides, unfortunately, is closed for refurbishing. It's called Thunder Mountain, and that we'll just have to deal with that.
Yeah, oh, is that getting refurbished?
Yeah, so it won't be open till I guess maybe even 2026, unfortunately.
Oh my God, what are they doing?
I don't know. I guess they're putting in a new track. It's a roller coaster.
Holy cow.
So
Oh my God.
I'm making you some some food. So because I know that there is some compliant food at Disneyland. My friend goes all the time. She says you can get a baked potato, but it's like $15 or something. So I bring as much food as possible, and
Oh my God.
I bring my favorite thing, and I've got to shoot this recipe because it's my very favorite thing. It's gingerbread granola. It tastes like cookies, but it's so
Oh
good.
really?
It just keeps you full. I need to feel full so that I can wait in those lines in the cold,
Oh my
cold.
God. Oh my God. Alona's bringing, I think she's going to bring them these gluten-free, no oil, sugar, salt, cinnamon rolls. And she made them for
Wow.
Kylie's birthday, and they were fantastic. Oh my
Oh,
God, we ate like a ton of them.
what
I haven't had a
recipe
cinnamon roll. I haven't had a cinnamon roll in like 20 years.
what recipe did she use?
It was funny. She used ChatGPT to search, and ChatGPT gave her this fantastic recipe. And then she's trying to find it online. She couldn't find it. So she thinks ChatGPT made it up.
Oh my God. Well,
So
maybe she
AI. made up a cinnamon roll. I don't know. Maybe we can figure out who made this to give them credit, but we're just using it inside our home. So hopefully no one gets upset if we're using it into someone else's, but it's delicious.
I'm
Holy
gonna put it
cow.
in Chat GPT. A vegan, gluten-free, oil-free, cinnamon
Salt, sugar free.
fun
She used date
recipe.
sugar. She used date sugar. So you tell ChatGPT they can use date sugar.
Uh-huh. Okay, I'm doing that without any
And,
salt or sugar other than, maybe she
and
can come
date
on
sugar.
the show and make it.
Oh my God. She did
Was
a
there
fantastic
frosting?
job. There was a frosting that she could make, but everybody loved them without the frosting. So we didn't even have to do the frosting.
Okay, so did her recipe have 2 cups gluten-free all-purpose flour, 1 cup almond flour, flaxseed, baking powder, baking soda, cinnamon, 3 tablespoons date sugar,
No,
unsweetened
no, we could have her.
applesauce?
She saved it. She saved it. I should have her send it to you.
Wow, that'd be something.
Oh my God. I couldn't believe it. And the kids loved them. So it was a huge win.
Oh, sounds fantastic. Yep, and it was supposed to rain, but it's not going to rain, so we're going to have good weather.
Oh, good. Good, good.
Yeah. Well,
Well, I want to tell you one more time, though, just how appreciative I am of you, AJ, for getting me into improv. I've been having such a good time, and I had no idea how helpful it would be towards my healing and personal growth. All the things, whether it's being okay, like making stuff up in the moment, or bombing, and everybody still likes you and laughs and claps for you. Or here was the big one that happened last night. I have a challenge. Like I'm always sort of keep my emotions, don't wear them on your sleeve. And last night, Patrick said, Matt, you're talking about being, anxious, but you don't look anxious. So he was like, Matt, I need you to show the emotion. And I was like, actually really nervous to come out and show emotion as the character, but it was so healing to like force me out of my shell like that. So it's just a gift that keeps on giving. And I know you said it was addictive. I thought you were crazy,
no,
but
it
I'm
is.
loving it. And Patrick is fantastic at balancing, giving like authentic, clear feedback and like understanding exactly like the emotional intelligence of why it's funny or not funny and communicating it in a way that doesn't stimulate shame. Like, I mean, I can't say enough about Patrick and watching you show up. It's like when you take on a character and then you like all of a sudden have this voice. I'm like, where's this voice?
Yeah.
Or whatever. And then in fact, I tried doing that, showing my daughter. I'm like, this is what AJ does. And I think she puts her tongue in her mouth. And I'm like trying to talk like that. And
Yeah,
and,
you
and
just,
Jordan's trying to talk
well,
like that. So we're both talking.
it, it's just you do stuff and then the character comes out of it. You do
Yeah.
something like you can talk. People that don't do improv will think this is absolutely crazy. But if you're willing to do all this nonviolent communication and talk to your
Yeah.
parts, improv can't be half as scary as it is probably to other people.
Oh my God. But anyway, so just thank you. That has like been what a gift for the last few weeks and making that happen. So thank you.
Absolutely. Well, thank you for all you've done for me. I really appreciate you helping me through this, I don't know, quagmire of cancer conundrum.
Oh my God. It's a gauntlet, but I think we're getting the clarity and there's an alignment of a lot of the experts all on the same page here and or getting comfortable with this page
Yeah.
and supportive.
I wonder what Dr. McDougall would have thought of immunotherapy because that never came up because I had never even heard of it until recently.
Yeah. No,
Yeah.
his most of what he talked about. I don't know if maybe he has patients that saw Dr. McDougall and were getting immunotherapy, and maybe they could share what that experience was if they were comfortable. But when I was training with McDougall and learning from him, there was not the immunotherapies and these targeted therapies. It was all about surgery,
Hmm.
conventional chemo, and radiation, and it was challenging. The data wasn't great.
Yeah. So people are asking, will the fires be where, I mean, it has the fire smoke damage have gone all the way to Orange County? Could it have traveled that far?
I mean, will the fires affect the
Yeah,
Disneyland?
Disneyland, like, will there still be smoke in the air, you think, in Orange County?
Um, No, I don't think so. There might be, uh, some. I don't know what it's like in Orange County. I'm in Los Angeles, and we're outside, and we're doing okay. And there's a lot of people that have been disrupted and really struggling, and thank God that we're doing okay, and our hearts go out to them. It's crazy out here, but I don't believe that that's going to impact Orange County.
Yeah, that's good. So people are saying there's life after death. Yeah, but you don't get to eat on the other side, I'm told.
That's well intentioned and probably hard to hear at the same time, right?
Yeah, absolutely. All right. Well, this was fun and as fun as it can be. We're making cancer as fun as it can be. And I'm sure you'll be back and we'll have more to tell once we know what we're doing. And maybe I'll even broadcast live from the infusion center if they let me. I don't know what they have. They might have privacy rules. They do give you
Oh
your,
yeah,
it's kind of like it's not your own room, it's kind of like your own cubicle, some
yeah.
curtains here
Oh,
and
I
there.
see, I see.
Yeah.
Yeah, yeah. They might struggle. I don't know.
Yeah, so we'll see if they let me do that. But you get to bring a friend,
Okay,
and I'll be bringing Snoopy with me. That's my new friend. All right. Well, thanks so much, Matt, for everything. See you
thank
on
you.
Wednesday at the Magic Kingdom, the happiest place on earth. And thanks all of you for watching and for your care and your concern and your prayers and your jokes. We really appreciate it. Come back tomorrow at 10 o'clock. Do you know Dr. Ron Weiss? You'd like him because he's a mensch.
Dr. Ron Weiss.
Yeah, I think you'd
Well,
really like him. His
okay.
father had cancer and he's just a real mensch. He comes on the third
Uh,
Friday of every month, but because this is Thriving in the Face of Cancer month, he's going to talk exclusively about how he's an internal medicine doctor at a farm in New Jersey, and he's also a regenerative farmer, and he's going to talk about things. He's really into like mindfulness training to help people with their well, just with life, but also with chronic diseases and diseases like cancer.
hmm. Okay. Yeah, I'll have to look him up.
I,
Sounds like a
he's a
interesting guy.
he's a good